The responses to ibrutinib in the relapse setting, ibrutinib is typically, or any of the BTK inhibitors, this patient's response was pretty typical. Most of the patients that I see, if they have palpable lymphadenopathy, they're going to notice a difference within days to a few weeks in that lymphadenopathy. So you get pretty rapid shrinkage. Patients who are fairly symptomatic, I also notice that they often start to improve in their fatigue, their night sweats, weight loss. Those sorts of things happen pretty quickly with ibrutinib. Now, fatigue is a common side effect of ibrutinib, so patients who feel well before going on treatment and don't necessarily have that side effect from their disease may notice some fatigue with the initiation of treatment. But in general, it's typically a very quick drug, quick onset of improvement in symptomatic disease. Patient compliance is always a concern when you're giving an oral therapy, because when you give an IV therapy, they have to come into the appointment, they're coming, they're getting the full dose of it. When you have a patient who's on an oral therapy, there's always concern, are they taking it at the right time? If they miss a dose, are they taking additional? I think my experience in general is that while compliance can be somewhat of an issue with oral medications, that a lot of patients get rapid improvement when they start these BTK inhibitors, and so they're feeling better. They've noticed improvement in their disease. They've noticed improvement in their symptoms, and so a lot of people do well with compliance just because they associate and know that taking that drug, that it's working, and that, I have many patients who will set a phone alarm so that they take their medication every day at the right time and aren't missing it. Common toxicities and management with ibrutinib. So the more common toxicities we see, there's loose stools, diarrhea, nausea are frequently reported with ibrutinib. For some patients, it's just a matter of, it's not actually diarrhea, it's more frequent stools, so they just watch what they eat or time out what they're doing during the day. I find the anti-diarrheal agents help very much with that. Arthralgias, myalgias can be common when ibrutinib is first started. Most of the time they're random and they don't last long, and if people can get through that first few months of therapy, that will improve with time. Bruising is commonly seen with ibrutinib. This is something like you see when a patient takes a daily aspirin. As patients get older, they often bruise easily. This is not typically harmful to patients in any way. And again, just recognizing that unless there's a reason that it's really bothersome to them, they're okay to continue on with their medication. I do think if patients are having problems that they're unable to tolerate, that a dose reduction, so taking the pill down by 140 milligrams, ibrutinib from Mantle is a 560 milligram dose. The 420 milligram dose is what's used in CLL, and if patients are having toxicity unresponsive or that they're not able to tolerate, taking it down does typically help with that. A few other things that I would comment on are rash can be seen when ibrutinib is first started. Just simply maybe holding the drugs for a few days, using over-the-counter antihistamines, or using a steroid pack will typically help with rash, and that won't be a recurrent problem or an issue. And then the atrial fibrillation and hypertension, I find the atrial fibrillation just has to be recognized that it's there. It can be treated just like any other atrial fibrillation can be treated in a patient not on ibrutinib, as long as it's tolerated. Most often, patients won't have to come off therapy for that unless they have pretty resistant atrial fibrillation. Hypertension can get tricky to manage, but again, is just managed. You have to just keep an eye on blood pressure and use antihypertensives as you would in a patient not on it. Ongoing gaps in the care of mantle cell lymphoma, there's a few big areas of study. So while the BTK inhibitors are very effective, there's still more patients are going to relapse from their disease. And so trying to prolong these remission durations and deepen the remission durations with single agent BTK therapy, there's a lot of interest going into trials with multi-agent, including multiple oral agents. So adding the oral BCL2 inhibitor venetoclax to ibrutinib has shown some promising results. Studies looking at adding the oral immunomodulator lenalidomide to a number of these different oral BTK inhibitors to really try to prolong and deepen the remission durations. The other area of interest is in patients with bad prognostic disease, so patients with blastoid histology, with TP53 mutations that do poorly in general, even with ibrutinib therapy. They have either worse progression-free survival, or the TP53 mutated patients have worse overall responses even to therapy and lower progression-free survival. So treating these high-risk population of patients is of high interest. I think probably the most exciting ongoing thing in mantle cell right now is results of the recent ZUMA-2 study, which was the anti-CD19 chimeric antigen receptor T-cell therapy in relapsed refractory mantle cell lymphoma patients. All patients on that trial had been treated with prior BTK therapy and had either gone off due to progression or intolerance to those. And this showed very high response rates. Almost everybody on the trial responded to therapy, a 97% overall response rate, with 67% of patients achieving complete remission. So there is toxicity associated with this, similar to what there is in large cell and follicular, with neurotoxicity and cytokine release, but very, very promising results, unprecedented results in a population of patients with very poor progression-free survival and overall survival. And so I think that one of the most exciting things will be looking forward to that approval, and then CAR T cells that can be even better with less toxicity.